Hello everyone, I'm Christy Risk, Senior Editor at GenomeWeb, and I'll be your moderator for today. The title of today's webinar is Validating a Diagnostic Mass Spec Platform for a Molecular Pathology Service Lab, and our sponsor is Agena Bioscience. Our panelist today is Dr. Douglas Demetrick, Director of the Molecular Pathology Laboratory and Program Leader for Research and Development at Calgary Laboratory Services. You may type in a question at any time during the webinar. You can do this through the control panel, which usually appears on the right side of your screen. Click on the Q&A box in the control panel to ask a question. Please make sure the drop-down menu says All Panelists. If you don't see the Q&A box in the control panel, move your cursor over the main panel until you see the control icons on the bottom. Select the Options menu and then select Q&A. We will ask the panelists questions after the presentation has concluded. Dr. Demetrick, please go ahead.
Thank you very much, Christy. I'll just enable the presentation. I hope everyone can see it okay. Thank you very much for the introduction. I'm delighted to be able to speak to this topic, as usually I'm presenting something more esoteric on cell cycle regulation or other growth pathway regulatory events. And I also appreciate the forum as a greater chance to irritate people rather than speaking in a small room. I'm talking about something more applicable to clinical service than my usual talks, and I'm happy to talk about our experience with the Agena MassArray platform in a year or so since we implemented it in Calgary. I first of all have to disclose that I've served as a consultant to AstraZeneca, Bayer, and Novartis, that I receive proceeds from intellectual property related to the study of the P16 gene or protein or use of anti-P16 antibodies. And I've received honoraria from Agena for presentations in the past, and including this one. What I hope to present today is our rationale for a selection of the Agena MassArray platform in our laboratory, how we've established and validated the assays, how we use the platform in our diagnostic setting, and maybe some applications that we hope to be able to utilize in the future. I have to apologize for not successfully getting rid of the flu, but I hope you can still understand this presentation in spite of it. For those of you who are not Canadian, I think it's important to explain our context. In Canada, essential healthcare services, including laboratory testing, are provided through funding by the provincial governments. Only non-essential healthcare services can be billed to a third party or patient, such as, for example, cosmetic surgery. Cancer tests are regarded as essential healthcare services and must be provided by a government-funded facility, and hence we are subject to a variety of pressures related to public sector funding than perhaps would be evident for a private laboratory. Now, Calgary Lab Services, the parent organization, provides about 35 million laboratory tests per year, of which about 400,000 specimens are surgical or cytopathology. We have a global budget of about $300 million to provide all testing to all patients in our coverage area, and we have a sole service contract to provide testing to the population of the city of Calgary and outlying areas of about 2 million people. Now, Calgary Lab Services provides all laboratory testing, including testing appropriate for quaternary care centers, and we're partnered with the University of Calgary Medical Center. And in that context, we provide molecular diagnostic services. There are 5 different independent molecular diagnostic laboratories within Calgary, and we cover hereditary genetics, molecular microbiology, molecular tissue typing, such as high-resolution HLA characterization, molecular hematology, which is related to testing of leukemia patients, and provision of some genetic tests related to hematologic disorders. The laboratory of which I am the director is a Molecular Pathology Laboratory, and we evaluate solid tumors, pathogens, and a variety of other molecular tests related to anatomic pathology. Back when we initiated the platform in later 2017, we were providing lymphoma testing using Biomed 2 primer sets for clonality evaluation and some lymphoma translocation analysis. We investigated solid tumors, usually for sequence variants, in the hope of providing direction to our clinicians with precision therapeutics, but also for diagnosis and prognostic decision making. These assays were primarily single target assays using a variety of methodology like quantitative PCR or snapshot-based techniques. Several of them were proprietary commercial kits, and they, as I said before, are directed to single targets. We also evaluated pathogens related to anatomical pathology problems such as mycobacteria and a variety of viruses. And we also provided some esoteric tests, microsatellite instability, and specimen identification, which we utilize capillary electrophoresis and STR short tandem repeat detection, which is the industry standard for those types of assays, as well as gene methylation evaluation of the 5' end of the methylguanosine methyltransferase gene to direct our neuro-oncologists. Our test utilization increases routinely about 20% per year, which I'm sure is not a unique problem to those of you directing molecular diagnostic facilities. So several years ago, we decided that we needed to consolidate as much of our testing as possible to a single diagnostic platform. We wanted to decrease our existing test cost, which was about $300 per assay, which meant if we wanted to evaluate a colon carcinoma specimen for BRAF, KRAS, or NRAS mutations, it cost us between $700 and $900 to evaluate those three independent tests. We wanted to ensure we had capacity for our annual growth and potentially extra capacity to increase our ability to attract contract research funding. And as I said, we wanted to standardize testing to a new platform to both simplify our methodology and SOPs and decrease our chance of errors. We wanted to, while we did this, conserve our analytical sensitivity of 3 to 5% allelic prevalence. And we wanted to conserve our turnaround time of 3 to 4 days. We wanted to enable multiple tests per specimen so that we didn't have to do 3 individual tests, for example, BRAF, KRAS, and NRAS in a colon cancer specimen, using 3 times the amount of specimen when we could look at a panel with one small aliquot as our specimen volumes, our specimen sizes are decreasing yearly. We wanted to, because we're an academic laboratory, we wanted the flexibility to stretch the application range of the platform and add new assays. We wanted the potential for adding a pharmacogenomics component if we were successful at gaining funding for that. And we wanted to avoid the problems associated with following variants of unknown significance. I undertook a broad due diligence, compared at least 3 different next generation sequencing solutions, as well as the Agena MassArray platform. I had a complex spreadsheet. This is a nice tool provided by Agena. I had a very clunky spreadsheet that evaluated infrastructure, informatics, labor, maintenance, reagent costs, consumable costs in the algorithm. And at the end of it, We very clearly identified that the Agena MassArray platform was the most appropriate platform for our needs, based on the criteria that I disclosed before, but also bearing in mind that the focus of our laboratory is clinical service, and that our research activities were essentially limited to contract research. The potential of decreasing our test costs to around $100 per assay versus the $300 per single analyte that we were experiencing before, and approximately $400 for the best next generation sequencing. The cost analysis looked very favorable. We had plenty of test capacity if we chose the 296-well instrument platform, easily allowing 40 to 60 specimens per day if we so desired, and ensuring that by spreading the risk of instrument downtime over 2 instruments, that we had a decreased likelihood of both instruments being down at the same time. We could standardize our testing to essentially identical methodology for most of our assays, and this standardization therefore allowed easy automation of sample preparation and assay preparation and evaluation of the results. Our analytical sensitivity was conserved, and in many of the assays was actually increased by moving to Agena reagents, and our turnaround time was conserved. The Agena panels and the ability to multiplex allowed us to create panels of 3 to 10 genes and 60 to 70 or even greater, depending on the PCR harmony of the various assays. This flexibility we've utilized already to generate 3 custom panels, which I'll discuss later. New panel addition was quite straightforward and takes us 2 to 3 months from conceptualization to validation of the panel on the platform and utilization. So speaking of validation, it was important, since we were making a total shift to a different platform. We validated all of the assays, of course. We wanted to ensure that we evaluated at least 30 specimens and a good mix of positive and negatives per panel. We, I think, facilitated the speed in which we were able to do this by proactively banking specimens that we thought would be useful for validation, and especially those specimens where we had sufficient material remaining from CAP, external quality assurance programs, because those are often very strange and interestingly complex specimens, which are very helpful for validation. Of course, these assays being based on essentially a glorified primer extension assay, we can test by observing wild-type signals in all of the assays where a wild-type signal remained, which excludes the UltraSeek assays. But even the high-sensitivity assays, there's a wild-type signal associated with a wild-type primer extension. But we chose to evaluate the most common targets as the main part of our initial validation. Now, due to the wide range of hotspot sequence variants that are able to be detected in both our custom and in the Agena panels, it was often not possible to test all of the different sequence variants, but we wanted to ensure we evaluated the most common targets. And the rare sequence variants that we could encounter over time, we would validate as we saw them, again by a different type of test, usually Sanger-based sequencing. So all of the targets that we used for validation have obviously been confirmed by either a validated diagnostic test or an accepted alternative technique like sequencing. And in doing so, here's an example of a benchmark from our colon high sensitivity panel in comparison to the assays that we were using at the time to provide clinical results. A sensitivity of about 96%, specificity of 99% is pretty good. Here's the spreadsheet for the colon HS validation. And you can see that discordance is illustrated by the pink or yellow boxes, and so there are very few discordances. Some of the discordances, frankly, could be expected. This very weak limit of detection from a previous diagnostic assay approximately 2 years ago, we lost the ability to see that with the Agena platform, and that may just well have been degradation of the specimen, which had been frozen in dilute quantity for 2 years. We also identified some potential additional positives, again, maybe because the Agena platform had a theoretically better analytical sensitivity than the current assay we were using for KRAS. But nonetheless, we calculated these all as discordances, and they're reflected in the benchmark that I showed you before. Similarly, we evaluated our custom neuro panel, and with that panel, you can see that we had very high sensitivity specificity as well. We had only a single discordance, and that discordance was a very weak identification of a histone H3 sequence variant that we interpreted as a false positive and calculated that as shown before. Now, the validation of the Agena fusion panels was quite a bit different. The assay is based on evaluation of messenger RNA because we're looking for a fusion transcript rather than a single nucleotide substitution or sequence variant. And the fusion assay is based on the difference in the ratio of the 5' end of the transcript versus the 3' end of the transcript. So in the ALK, ROS, or RET fusion genes that are evaluated in the lung fusion panel, the 5' end, or the first half of the messenger RNA, is replaced by fusion of a partner gene through a chromosomal translocation, resulting in a fusion transcript that's translated to a fusion protein. In this case, for all three of these targets, the kinase domain, which is the driving force for the chimeric or fusion oncoprotein, remains, but the 5' part of it can vary with a different partner. The important thing is that this transcript is upregulated as compared to the regular wild-type gene, and in its upregulated and changed protein regulatory profile, the driver of the kinase pushes proliferation of the cell forward. However, the kinase also serves as a target for precision drug treatment, so it's very important in order to be able to use that drug to identify this target. And this is a cartoon attributed as below on the screen, in which the 5' part of the ROS gene is replaced by one of several different partners, leaving the 3' end. And so if we evaluate a sequence on the 3' end versus a sequence on the 5' end of ROS, we'll find that because of this fusion protein, we'll get a higher ratio of 3' sequences over 5' sequences because the 5' part of ROS is actually completely replaced. And that's the basis of the assay. It looks like this. If we have a couple of positive patient specimens, we can see that the percentage of the ROS 3' signals of 77 or 70% is much greater than is normally expected of around 30 to 40%. So this high percentage of the ROS 3' end indicates in this assay a positive result for fusion, and it's independent of whatever the 5' partner is. And here's our evaluation of the fusion panel validation. We had ALK positive, ROS positive, RET positive specimens, and we had very high correlation with a single false negative for ALK and a potential false negative for ROS, albeit we had very few cancer cells remaining in this paraffin block. These are all paraffin block material. And it is likely that we actually were below the limit of sensitivity of this assay. So we were very happy with the lung fusion panel validation. And I want to interject a case illustration in here, because I like to do that to maybe firm up the clinical relevance of a presentation, but also to explain the advantages of having the ability to perform these tests locally and quickly. So we had the sad situation of a 33-year-old woman presenting several months ago to our teaching hospital with symptoms of increasing shortness and breath about a couple of months after delivery of a healthy baby. And in her workup, she had a shadow on a chest X-ray and was further investigated, and she had a lung mass identified on CT. It was biopsied and turned out to be positive for adenocarcinoma. And as you can see from this, this is a very high-grade, large cell, nasty cancer that was not amenable to surgical resection. So she was treated. First of all, the cancer was worked up in the hope that she'd be able to be a candidate for precision drug treatment. Her EGFR mutation profile was negative, and unfortunately there was no ALK fusion protein detected by immunohistochemistry. So she was treated with palliative radiotherapy to try at least to control the primary lesion, but in spite of that, her disease progressed rapidly over weeks. She developed increasing shortness of breath and was declining significantly. It was decided to investigate the possibility that she had a ROS-driven lung adenocarcinoma, and the specimen was sent for testing and to an external referral lab, and was found to be suggestive by immunohistochemistry of a ROS cancer. However, the IHC assay has a high false positive rate. So prior to therapy being initiated, we were requested to confirm the immunohistochemistry. You can see the immunostain shows a muddy brown cytoplasmic staining, but also some very good membrane staining. And this is highly suggestive of a ROS upregulation fusion protein in the context of lung adenocarcinoma. And we were very happy to confirm the immunohistochemistry with the Agena MassArray lung fusion assay. You can see, rather than the expected 30 to 40% that you get from a 3' end of these fusion proteins in a wild-type situation, we can identify 71% of the transcripts contain the 3' end, which is well into the positive territory. So this was very good news. The patient was started on crizotinib immediately, and within 72 hours had a dramatic improvement and a decreased need for oxygen that over the next few days improved even further, and she was eventually discharged on home oxygen approximately a week after treatment was initiated. In order to also facilitate patient care, we wanted to initiate liquid biopsy evaluation of EGFR mutations. So these are done in plasma, and specifically we're looking for the T790M EGFR resistance sequence variant that is selected for in disease that's initially responsive to anti-epidermal growth factor receptor treatment. But this is resistant to first-line anti-EGFR TKI treatment. And however, there is a very effective drug that can be used for it, but it requires, in order for the drug to be considered in Canada, confirmation that this predictive biomarker is present. Often these patients are very sick and are unable to be biopsied, so the ability to utilize blood allows these patients a good chance to be treated. And about half of first-line anti-EGFR resistant patients end up with the T790M mutation. So it's a significant potential clinical population. Now, aside from the situation with tissue where resection specimens or cytopathology specimens are fixed immediately and there's no further degradation of the nucleic acid, the blood specimens are just stored in tubes that preserve the blood but don't fix the tissue or the DNA. So over time, nucleated white blood cells will lyse and contribute their genomic DNA to the plasma, which only has a very small amount of circulating tumor DNA in it, and that's the basis of our test. So over time, lysis of white blood cells will actually compete out the ctDNA and make analysis much more difficult or impossible. So we tested two types of blood storage tubes, EDTA, which is standard, and Spec, which is proprietary and has and is expensive and not commonly stocked, but it does a lot better job at preserving the integrity of white blood cells. We also want to ensure that our platform had the analytical sensitivity to evaluate these specimens within a pharmacologic detection range. We wanted to ensure that we could purify these small amounts of ctDNA out of these specimens. We wanted to ensure that because of the ultra-sensitive assay, we weren't detecting false positives. We wanted to ensure that our assay was reliable and reproducible in comparison to external standards. And then we wanted to ensure that we had biological confirmation whenever possible with the original driver mutation from tissue. So we certainly didn't want to reinvent the wheel when we set up this assay. We utilized well-done studies of pre-analytic variables that have been published. But we did independently evaluate several of these parameters ourselves to ensure that, that we were on the right track in terms of setting up this assay. This is a nice little illustration of centrifuged plasma from blood stored in Spec tubes, days 0, 1, 2, 3, and 5. You can see that from the degree of hemolysis and pigment present in this centrifuged plasma, that there is erythrocyte lysis and leakage of hemoglobin into these specimens. However, the DNA yields from these plasma specimens were identical up to day 5, showing that the Spec tube did a great job at keeping the integrity of the white blood cells. So our cutoff for receiving these specimens is day 3, and that gives us a good buffer to ensure that the DNA quality is excellent of the plasma, the ctDNA specimen. This is an example of the T790M assay run using commercial standards. So a 0%, 5% allelic prevalence, you can see a very clearly identified peak. 1%, again, a very clear peak. And even 0.1%, you can see this peak that is detectable over baseline at exactly the expected molecular weight. And the advantage of the mass spec type of platform is the incredible specificity of the molecular weight, variation only of 1 to 2 Daltons in molecular weight ensures that this peak is the exactly expected analyte. We also want to ensure we can identify the driver mutations. Here's the common L858R activating EGFR mutation at 1% or at 0.1%. This one, this particular assay is very clearly identified over baseline. With our external quality assurance assay, we had 100% concordance with the expected circulating standards in a Canadian national ring study, aside from specimens that were in the 0.05% allelic prevalence range, which is below our 0.1 to 0.2% analytical sensitivity. And we initiated this assay and evaluated the first few specimens where we were able to get the original tissue status of the mutation. We had 100% concordance in identifying the original driver mutation in those specimens where we were able to detect an EGFR sequence variant. So we were happy that we actually have a robust, reliable blood-based assay for EGFR sequence variants. Now recently, we've implemented a couple of new activities or panels on the Agena platform. Melanoma is a very common tumor in Alberta, which shares with Australia as being a geographical jurisdiction with the highest prevalence of melanoma in the world. And so it's important for us to be able to identify the drug-treatable BRAF mutation in these melanoma specimens. However, the panel at the time offered by Agena, we didn't feel had an optimal level of analytical sensitivity. We wanted analytical sensitivity based in the HS, 2% allelic prevalence range, rather than the 5 or 10%, because we were evaluating very small primary specimens. So in the HS range, the BRAF that's interrogated in the lung or colon panels consists of these sequence variants. However, the BRAF that we needed to be the BRAF sequence variants we needed to be evaluated in the context of melanoma or histiocytic lesions or hairy cell leukemia or refractory to treatment thyroid carcinoma is a much greater range. So the only solution to this was to create our own panel. So since we were going through the effort of creating our own panel, we wanted to ensure that we included a few other mutations in there as well, and we were guided by the literature in this, in particular this very useful manuscript. And we partnered with Agena to use their proprietary technology to ensure that the analytical sensitivity of our new panel approached their HS level of detection. So here's an example of the increased range of BRAF sequence variants that we can interrogate by a hotspot in the MassArray panel. And the melanoma panel also includes a variety of other targets, GNA11, GNAQ, and 3 different RAS family members, in addition to KIT mutations of which arise in treatment of melanoma, and a few other useful diagnostic markers. So we felt we have quite a good panel, and we've validated this HS panel over the past about a couple of months ago, and it's in routine use in our lab now. The other thing that we've implemented is human papillomavirus panel. Now, human papillomavirus is reflexively evaluated in gynocytology specimens like PAP specimens, and people use high-volume automated platforms to do this. So I'm talking about HPV-associated cancers in the context of other anatomical pathology applications. Primarily, the exploding prevalence of HPV-associated oropharyngeal carcinoma. Now, the guidelines for testing of this suggest that aside from direct HPV evaluation, a surrogate marker, immunostain for the P16 protein, is a suitable surrogate to replace human papillomavirus evaluation for the purposes of prognostication of these oropharyngeal carcinomas. And this is important because HPV-associated disease has a much better prognosis, and therapeutic decisions, including surgical decisions, are made based on that type of information. So ordinarily, you wouldn't expect that we would need to do HPV testing in this context. However, it's becoming quite possible that, and obviously ongoing research is occurring as we speak, but it's becoming quite possible that HPV status can predict a much better response to immune checkpoint. HPV or other virus associated cancers can respond much better to immune checkpoint therapy than non-virally related cancers, including HPV. And in fact, and my thanks to AstraZeneca, who've allowed me to show this slide of one of their Raptor drug trials, looking at their immune checkpoint inhibitor, durvalumab, in patients who are with oropharyngeal carcinoma, squamous carcinoma, who are segregated by HPV status as positive or negative. And you can see a very significant difference in overall survival associated with treating those patients who are HPV positive versus negative. Now, of course, HPV-associated diseases, oropharyngeal carcinoma has a better prognosis to start with. So more work has to be done to ensure that differences in survival are not just due to the better prognosis, but are due to the immune checkpoint therapy being more effective in HPV patients. But these data, along with other examples in the literature or discussions in the literature, are very suggestive that our need to do direct HPV testing in cancer specimens is likely to increase in the future. The reason being that if you've got an 85 to 90% correlated surrogate test like you do with P16 to HPV status, for prognosis, a 15% discordance is not that big a deal. But when you're talking about $100,000 to $150,000 drug treatment, the extra 1 or 2 patients per every 10 patients that are treated maybe inappropriately with the expensive designer drug can make quite a difference that more than pays for your entire testing program. So I predict that in this context, we might see an increased requirement to do direct HPV testing. So we've been doing HPV testing for many years. We have an active HPV cancer research program, but also our pathologists like to use this test to discriminate between cancers of unknown primary or potentially metastatic versus new primary cancers, potential sex abuse cases, and to investigate esophageal papilloma. So we have a baseline amount of HPV testing routinely. And we had, prior to the initiation of the assay on the MassArray, a TACMAN-based test where we could evaluate 10 different HPV subtypes by quite a complex, labor-intensive quantitative PCR assay. And by accident, we identified Agena had an HPV panel that could evaluate 19 different subtypes in a single PCR reaction. So we were very happy to test this out, and also very happy to find that we could validate this assay very quickly, that we had very good results in comparison to our TACMAN assay with a lot less work and a lot less cost. And so we were quite happy with this MassArray assay in the context of genomic HPV or DNA-based evaluation. However, there is a school of thought that the transcript of HPV may be more clinically valuable to detect than the DNA. And the Agena assay gave us the theoretical ability to evaluate RNA as well. So we wanted to test that out. Now, the important thing with these is to make sure that the RNA is not contaminated with genomic DNA because we already know that this assay will detect a genomic positive very quickly. And so we had to design a few controls that were in addition to the Agena controls. As you can see, our control for genomic contamination is flat line, but our control for RNA quality is quite reasonable. So this is a specimen that is quite suitable for evaluation of RNA only using the Hpv MassArray panel. And lo and behold, we identified HPV16 in the RNA, which matched exactly the status from the genomic DNA evaluation. And the RNA gave a very good yield and a good signal. So HPV can be evaluated at both DNA or RNA levels, at least over the E6, E7 interrogation target. We do have a few things that we wish Agena would provide for us. One I'm going to talk about is the use of single nucleotide polymorphisms for DNA specimen identification, based specimen identification. There is a school of thought that you can evaluate as a quality assurance indicator a rate of unsuspected tissue misidentification amongst historical specimens, but as well you can use DNA identification to confirm specimen origins when a pathologist suspects there's been a misidentification or a specimen mix-up, or in the case where the pathologist feels that there's a possibility of a tissue contaminant or floater influencing the diagnosis of a specimen. As well, there also is a school of thought that suggests that as the cost of evaluating DNA specimen origin has come down significantly and the ability to perform this test is a lot more feasible, that perhaps surgical pathology specimens which infer a very high morbidity or a risky procedure in medical care for a patient should be confirmed to ensure that there's not been a specimen mix-up. For example, in the case of cancer-associated amputations or very high morbidity other treatments like high-dose chemotherapy. Now, the gold standard for evaluating DNA origin is to use microsatellite analysis. And there's a standard panel of 13 or 17 markers, and so we can compare two specimens, X1 and X2, and from the very first marker here, you can see that this XY, one allele from mom, one allele from dad specimen, is not matched to this female specimen. But you can also see that the other alleles don't match either. And this is the way the technique is done. However, it requires PCR and liquid capillary electrophoresis evaluation, and is not as sensitive as a potentially alternate strategy using single nucleotide polymorphisms. And the SNP for ID consortium has suggested a panel of 52 of these is enough to discriminate the population of the world, like the 17 marker microsatellite panel is currently the gold standard. And Agena does provide a sample ID panel based on SNP analysis that has, I think, somewhere around 30 of the SNP for ID markers in there and a variety of other markers. And it has 44 markers. And this is more than enough to distinguish very quickly, I think in a single well PCR assay, very inexpensively, the origin of different surgical pathology specimens. The problem is that if one wants to participate in an external quality assurance program, there is no way to be able to report the results using SNP-based forensic identification testing. The reporting is using the gold standard, which is STR-based microsatellite analysis. So if we want to satisfy our accreditation requirements by participating in external quality assurance program, at the moment we can't use SNP-based identity testing because we have no way of reporting this to these QA programs. The other thing on my wish list is the ability of using the Agena platform to detect NTRK fusion assays or some sequence variants of NTRK gene. And the reason for this is that, like the situation in lung fusion cases, fusion of the NTRK, and there's 3 different NTRK genes, so fusion of any one of the NTRK genes with another fusion partner can lead to a chimeric protein like the chimeric ROS or chimeric ALK or RET proteins that can drive a cancer phenotype. Well, the chimeric or fusion NTRK proteins can drive a cancer phenotype in a variety of different tumors, including some sarcomas and some lung adenocarcinomas and other epithelial tumors, as well as some pediatric tumors that are very difficult to treat. However, there have been developed some very specific designer drugs that can target the active part of the TRK protein, which is the product of the NTRK gene, that remains in the fusion protein and can be associated with really dramatic clinical responses. So because this drug has now been FDA approved in the United States, I think as of November 26th, and over the next few months I expect it to see it approved by Health Canada and hopefully funded by Canadian provincial governments, it will be very handy to be able to evaluate these NTRK fusion proteins in the context of our molecular testing program. Now, over time, resistance to treatment has been reported in the clinical trials, and these are due to a finite number of sequence variants that again are amenable to evaluation on the Agena platform by hotspot analysis. So those are my wishes for some future applications. Now, we've talked about a lot of positive experiences with the MassArray platform, but I have to say that we found a few negatives as compared to what we expected. We found that the analysis of the data was a bit more labor-intensive than we expected, and the analysis of the custom panels was even more difficult technically than the Agena panels. These are very manageable, but nonetheless, to be fair, were unanticipated. As well, the machine is required to be tuned a bit more frequently than was suggested originally. Again, this is very manageable and not a big deal, but was different from what we expected. So let me explain the data analysis issues in a little bit more detail. If you look at the report from an Agena commercial HS panel, in this case it's HS lung, if we select a peak intensity or a threshold of detection of 8, we get a very nice clean report where the sequence variants for each particular clinical sample are listed and very, very obvious. However, we're missing a few of the positive controls at the 2% allelic prevalence level. In order to ensure that we pick those up, we have to adjust the gating down to a peak intensity of 4. When we do that, we get a variety of false calls from the machine. These have to be inspected by eye and eliminated, which is quite easy to do. These are very obvious false calls and eliminated by eye in comparison to the detection that we would expect for a true positive. But nonetheless, it requires some time and it's quite tedious to be able to do this to ensure that we detect all of the sequence variants that we need to find in our 2% analytical sensitivity control. The same thing obviously occurs with the custom panels, except we don't get quite as nice a report. We get a bit of a clunky spreadsheet, which is a little bit harder to evaluate. But again, the false machine calls at a level of sensitivity that's sufficient to detect all of our control sequence variants can easily be eliminated by eye, or confirmed by eye in the case of the red for elimination and the green for confirming a machine call. So we've had the platform for just over a year, and I want to show what outcomes we expected versus what we actually achieved. So at the beginning, we identified potential significant cost savings over not only our current assay costs, but over potential competition from next generation sequencing platforms. Was this actually true once we'd used the platform? Well, it certainly was. Our assay costs are in the hundreds of dollars for our main panels, lung, colon, HS, or our custom neuro panel, versus anticipated costs of $400 to $500 Canadian, and all of these costs are in Canadian, so they're all relative to each other, which my Canadian colleagues tell me is quite typical for NGS costs. The validation was very smooth, and we validated these three major platforms in less than a month after actually unpacking and plugging in the instrument. The analytical sensitivity and turnaround times were exactly as expected. In fact, many of our assays experienced an increased analytical sensitivity, which was excellent. Our turnaround time of 3 days looks very favorable compared to what my diagnostic colleagues tell me is appropriate for next generation sequencing of 2 to 3 weeks. And over the past year, we've utilized the lung panel almost 600 times, colon panel 350 times, the neuro custom panel 273 times, and we anticipate over a year to use the lung fusion panel 56 times, UltraSeek lung liquid biopsy assay 120 times, our custom sarcoma panel 20 times, and our HPV panel about 80 times. These latter tests are projected over a year since they've been offered for less than a year. Here's our current molecular testing requisition, and you can see about half of our assays have been ported over to the Agena platform in the first year. These virus assays are currently being moved over to the Agena platform. And as I said before, we'd like to be able to use the identity confirmation assay, but can't quite yet. So in summary, I hope over this presentation, I've shown you our rationale for selection of the Agena platform, our establishment and validation of the platform and the assays, the range of use in our diagnostic context of the platform, and future applications that we are either currently moving towards in our laboratory or are hoping that Agena will develop to further extend the range of the platform. Of course, I have to acknowledge people who are really important in this process. Bob Winkfine, Marco Perazzolo did the bulk of the assay establishment and validation on the new platform, while the rest of our laboratory of 5 were providing the diagnostic workload as our request for labor and our funding budget was slashed, so we had to both perform our current workload of testing and implement the new platform with the same staffing. And these guys did a fantastic job and gave me some very nice images, which I used in the talk today. As well, Priscilla Hunt and Daryl Irwin from Agena were fantastic resources in troubleshooting and in helping to design our new assays. And Daryl has also been very polite with me in my numerous suggestions for improvements or expanded capacity of the Agena technology. So thanks very much to all of you guys. And that completes my presentation. I'd be very happy to take some questions. Thank you.
Thank you, Dr. Demetrick. As a reminder to webinar participants, if you have a question, please type it into the Q&A box in the control panel. And before we begin the Q&A, we'd like to ask attendees to give us feedback by taking our exit survey after the webinar. All right, we'll now start the Q&A. Doug, in the Spec tube experiment, you said the yield of the DNA was equivalent to between 0 and 5 days. Was the quality of the DNA affected?
Nope. By that statement, I meant that the yield of ctDNA was essentially unchanged between 0 and 5 days, which meant that there was a negligible amount of white blood cell lysis contributing genomic DNA, and the quality of the DNA that we isolated from the ctDNA seemed similar. And was able to be used successfully in the Agena assay because there is a quality indicator control within the assay. So all of the time points provided DNA that was usable in the UltraSeek assay.
And how many samples per new panel do you actually need to run according to your guidelines?
So the sort of, and this is an argument that occurs in the context of all diagnostic molecular validation approaches. Typically, folks use 30, which was based on some outdated statistical assumptions, and there's really no guideline that I've seen of how many of these are supposed to be positive versus how many are supposed to be negative. We like to ensure a minimum of a third of the specimens are negative specimens to ensure that we're successfully evaluating a false positive rate. And we like to ensure at least 20 of the 30 are true positives that have been validated by an alternate method. And those would be minimums for where we can obtain specimens. I'm not sure we were successful in evaluating 20 positive for the lung fusion panel. We're pretty close. I should actually go and count, but we're close. So that's our kind of guideline. Usually we're well above that. We're in the 50s or 60s, of which 40 to 50 would be positive samples. And we hope that of the positives, we hit all of the commonly expected targets and as many of the unusual targets as we're able to evaluate, but we are not able to evaluate all of the rare sequence variant analytes.
Could you talk about some of the advantages of the MassArray compared to next-generation sequencing?
Okay, well, NGS, to be honest, when we started the due diligence, we thought that we would end up with an NGS platform, which was frankly kind of an unpopular idea to our finance department. So I decided I would approach this with an open mind and evaluate a variety of different criteria, no matter what the platform. And we found that there was a huge difference, bearing in mind that we did this a couple of years ago, in cost, but also there were a lot of other disadvantages in our particular testing context with using a next-generation sequencing platform. Not to slag the technology, but to say that there were pressures for us that were maybe different from others. And so not only was cost a significant pressure, turnaround time was a significant pressure, and again, our turnaround time of 3 to 4 days was not essentially allowed to be degraded. We also were worried about the responsibility of following variants of unknown significance. So the idea of a hotspot, a selection of specific targets to interrogate versus identifying a bunch of targets that we were unable to interpret in a clinical context was attractive, and that was with the Agena platform. We also, because research is not a significant mandate for our laboratory in the context of this government-funded laboratory, the ability to use NGS to identify unknown targets, which is very attractive in a research context, was simply not a criterion for us. And so when I looked at all of the criteria, the ability to add new assays and quickly validate and quickly evaluate the data, the Agena platform in our diagnostic context was a very clear winner.
Okay, great. I'm afraid that's all the time we have for today. We'd like to thank Douglas Demetrick and our sponsor, Agena Bioscience. If we didn't have time to get to your question, we will try to follow up with our expert. As a reminder, please look out for the pop-up survey after you log out to provide your feedback. If you missed any part of this webinar or wish to listen to it again, a link to an archived version will be emailed to all attendees. Thank you for joining us for this Genome webinar.
Thank you.